Hi, everyone. This is Samira Daswani, the host of the podcast, The Patient from Hell. This is part two of an episode that we've recorded with Dr. Douglas Blayney, who is a renowned clinician in the space of medical oncology. He has been practicing for many, many decades and has an incredible depth of experience across many facets of the oncology experience. But most pertinent to our discussion today is he was the former president of ASCO. And if you heard our first part of this small series, you'll get a depth of what ASCO is, what they represent for the space, and the impact they've had since 1964. So, this is part two, where we're going to dive into the learnings that happened from the conference in June 2023 and what has sort of come from it. So, with that, Dr. Blayney, welcome back.
Thank you, Samira, and thank you for your attention to your audience as well. My pleasure to be here.
Dr. Blayney, I'm going to jump right in. So, June 2023, McCormick Center, Chicago. We start on Friday, goes on till Tuesday. Um, what happened this year? Can you talk to us about what the theme was? We spoke a little bit last time about one of the changes in breast cancer. What else has come from the conference this year?
Well, I'm not. I don't plan to go abstract by abstract. There were many abstracts presented. I think, a particular interest to the breast cancer world was the emerging role and trying to figure out where the CD46K inhibitors are going to be used or should be used in the treatment of endocrine responsive or hormone positive breast cancer, either early stage or potentially curable, or in the metastatic setting where we're trying to prolong and slow down the growth of tumors. So that's perhaps one theme. Second theme in breast cancer is the greater importance of somatic cell or DNA testing, particularly circulating tumor DNA testing, and how that should inform treatment choices, both initially and further down the road, and also in the timing of changing treatment courses, moving from treatment that's not effective and getting an early warning that the cancer may be growing and progressive. And third thing that I took away from many of the sessions is the emerging role of antibody drug conjugates. So many of your listeners may be familiar with Herceptin or trastuzumab. Trastuzumab was first developed in the early 1990s. It's now what we call a naked monoclonal antibody. So it's an antibody has a recognition site that attaches to or gloms onto a antigen, which is typically a protein, either circulating in the blood or on the cell surface. And effective monoclonal antibodies prevent that cell, if in this case a cancer cell, from growing or proliferating, and may actually kill it. So anyway, now since monoclonal antibodies recognize antigens, several things have happened. One, they've been attached to either typically now an intracellular poison. So when the antibody attaches to a cell, the antibody, as part of the normal process, gets engulfed into the cell and then gets digested by the cellular mechanisms, and that's the normal process of things. Whether it's a therapeutic monoclonal antibody that is administered to a patient, or an antibody that you and I develop in response to a stimulus like a virus or a bacteria, that antibody gets metabolized or disappears from our body. Well, various investigators have recognized that if you tag a poison to that cell, tag a poison to that monoclonal antibody, as when that monoclonal antibody and the poison gets taken into the cell and digested, if the poison is not metabolized or deactivated by the cellular mechanism, the poison is free to do its job in that cell, and that's a very targeted approach to, in this case, cancer.
Hmm.
So, as I started with, Herceptin was developed against what's called the HER2 antigen in particular sites and Perjeta, which is a modification, pertuzumab, a modification of Herceptin, targets a little different site on the cell surface antigen. So this technology has expanded. Rituximab, which targets a B cell antigen, is used in the treatment of lymphoma typically. Is another widely used monoclonal antibody. 10 or 15 years ago, investigators recognized that if you first of all, if you attached that antibody, that poison, it was effective on the cells that express that antigen. Similarly, there have been a wide expansion of targets, and each of those targets can be targeted by its own monoclonal antibody. So CD19, there are is another monoclonal antibody or another target for a monoclonal antibody in lymphoma. There are other targets that are used and are developing in other kinds of treatment. And to complete your question, the fourth thing is, artificial intelligence, or AI, probably has a role in something in cancer treatment. We don't know what it is yet, but boy, it sure sounds cool. So those are the, again, other attendees may have different takes on various things, but those are what I thought was important for breast cancer, but also important for our field as well.
Dr. Blayney, can we go back to number one? Can you talk a bit more about what is a CDK4/6? Why is it relevant? Can you spend a little bit more time on that?
Okay, we talked about some of this in part one of this series, so in estrogen receptor positive breast cancer, in other words, breast cancer cells that express, actually it's an intracellular protein, the ER receptor, but targeting in some way, either locking up that ER receptor prevents it from doing its job, which is when it's stimulated, when the ER receptor, it's double, then the estrogen receptor is stimulated by estrogen, it then goes to the nucleus and turns on the cell and say, grow and multiply. So traditionally, there have been two approaches to inactivating the estrogen receptor. The first one was a false ligand or false binder to that, which was tamoxifen and similar drugs, which bind to the estrogen receptor, lock it up, and say no, and prevent it from going to the nucleus and getting and making the cell grow. The other mechanism for turning off estrogen stimulation of estrogen positive cancer cells is turning off estrogen production in the body. So, and that's typically the aromatase inhibitors, of which there are three. And when a woman and a man, actually, a woman's main, premenopausal woman's main source of estrogen is the ovary, and the aromatase inhibitors aren't effective in premenopausal women. You have to shut off the ovary. But other sources of estrogen are the breast itself, as well as the adrenal glands and the fat cells. But anyway, so the aromatase inhibitors prevent estrogen manufacture in fat cells in the breast tissue, and also may interfere with adrenal production. But anyway, so the long way to get to the point is that when that estrogen receptor growth pathway is shut down, the cell compensates, or many of the cancer cells compensate by revving up or turning on or making more sensitive this CD46K pathway. And it turns out that if you combine estrogen blockade with blockade of the CD46 pathway at various steps, you can have a augmented or more effective therapeutic approach. There are three CD46K inhibitors. Palbociclib was the first one to be shown beneficial in metastatic breast cancer, and also probably beneficial in early stage breast cancer, both combined with estrogen blockade in other ways. The next one is abemaciclib, which is also a CD46K inhibitor, has a little different side effects than palbociclib. And the third one is ribociclib, which also works through the CD46K inhibitor pathway, but also has has a different side effect profile. So that's sort of a long-winded background on estrogen receptor blockade, as well as CD46K.
Dr. Blayney, I'm going to ask you a clinical question. So if we have a patient, just case study question, and we absolutely have disclaimers that this podcast is not medical guidance, and you as a patient need to talk to your clinician, and this is not medical guidance. So with that sort of backdrop, if you have a patient who has been on, say, an estrogen blocker for, 5 years, and they are looking at the data from ASCO, and they are reading all this news about ribociclib coming out, improving survival, how should a patient who is currently on an estrogen blocker think about the news from ASCO?
Well, in this scenario, again, you pose, and again, this is not medical advice, but the things to think about are what is the patient's risk of developing a recurrence of their cancer, and also what is their tolerance of new medicines, and how much okay, so those are the main fundamental things one should consider. Secondly is these studies were not designed to answer the question you pose, because they were all of the CD46K inhibitor, palbo, ribociclib, and abemaciclib, were designed to be given simultaneously with the first endocrine manipulation. And you can see why that is. If you want to turn off both pathways at the same time to get maximum benefit, we just don't know what adding, again, in the adjuvant treatment, or we don't know what adding 5 years down the road any new non-endocrine treatment is beneficial. Similarly, in metastatic breast cancer, we don't know. The only thing we can say about, or I think the only thing we have randomized trial evidence for at that 5 year point is, gee whiz, should I go on to another 5 years or another 2 years? There is randomized trial evidence that sometimes that can be helpful, but using that as using that 5 year addition as a paradigm, it's very small benefit and likely only to be beneficial in someone who has a very high risk of recurrence. Going on that theme, the breast cancer index may now provide some quantitative information as to how high risk of recurrence someone is and whether that 5 year benefit exists, or additional 5 year benefit exists. But that, gee whiz, that's taken 10 or 15 years to develop an evidence base where we can say with some assurance. So I think the takeaway I think is, boy, this is ask your doctor who knows you and your risk tolerance, and also can maybe opine on the benefit in your particular case. But also that there are now 3 drugs, CD4/6K inhibitors, that may have almost interchangeable benefit, and we can and we can adjust the based on side effect tolerance. And soon, to our earlier point about the business medicine, when in a market which is mildly constrained by, which is very much constrained by regulation, but mildly constrained by payment policy. When you have 3 entrants in the market, that's sort of when I think the economist might say that's when we get price competition. So I think in addition to the clinical benefit of having multiple drugs available, there may also be a pharmacoeconomic benefit to having multiple drugs available.
Thank you. That was awesome. I would love to do the same thing for theme number 2, because I think theme number 2 that you highlighted was the importance of somatic mutations, and then maybe circulating tumor DNA. So if you don't mind, can we do like definitions and then talk about kind of what
Okay.
happened at ASCO?
So as I think most of your listeners know, or viewers know, DNA is the code that drives what happens to our cells, and turning on or turning off DNA and its translation into RNA and transcription to proteins is what makes, among other things, my hair gray now and my eyes green, where, yours, what's happened to DNA in you is different. So anyway, there's the way to think about this is there are 2 kinds of DNA. There's germline DNA, which is present in every cell in our body. Then there is somatic mutation, which happens to various cells, and an accumulation of somatic mutations, whether it's in a breast cell or a lung lining cell or a colon lining cell, an accumulation of those mutations in the right spot can lead to a cancer. So in your viewers and my patient's mind, it's very important to distinguish germline DNA from somatic mutation or cancer cell mutation. So germline mutation, that's a whole nother topic. Your viewers maybe have some knowledge of the BRCA BRCA1 to check to other germline mutations, which can predispose to cancer. Somatic mutations occur, when we walk out in the sun or we take a high altitude airplane flight. We're exposed to ionizing radiation, which can damage our DNA. Fortunately, the body has multiple mechanisms to detect and repair that damage, so we don't get cancer immediately after an airplane flight or even standing. Yeah. So there's big science around ionizing radiation. We don't need to go there, but suffice to say that these do cause typically repairable mutations. When cancer develops, often there are detectable somatic mutations, not in the 20,000 genes we have, we know about certain somatic mutations, and probably in 25 to 30% of cancers can a somatic mutation be detected. Let me just say a somatic DNA mutation can be detected. Many of those mutations that we know about can't be targeted with drugs. In other words, no one's been able to design a drug that we can swallow or inject that gets to the DNA before being metabolized or detoxified or disarmed by the body's own protective mechanisms. But anyway, in breast cancer, because we've generally had the luxury of estrogen receptor positive patients, which is estrogen receptor positive tumors, not patients, but tumors. We have had, we've been dealing with targeted therapies all along. Contrary-wise, in lung cancer is now really a disease of targetable mutations. There are still some smoking related lung cancers, but many lung cancers now are driven by somatic mutations. And there are more and more drugs that are available to target these specific somatic DNA mutations in lung cancer. In other cancers, it's coming along. Colon cancer is one where targetable mutations, which are tied up in MSH or multi. Anyway, so there are somatic mutations that are targetable in other cancers. In breast cancer, it turns out, even though it turns out that the drug, a pathway called PI3, or a step in a pathway called PI3 kinase, is mutated into the on position in about 50% of breast cancer patients. So we've learned over the past 10 years that targeting that PI3 kinase mutation can switch that step to off, at least temporarily. But as I said, cancer cells are pretty clever in mutating around and getting away and restoring that growth signal or growth impetus in spite of the targeting of that DNA mutation. So we're learning more about the importance of detecting somatic DNA mutations in breast cancer, which sort of leads me to your next next question about circulating tumor DNA. It's been known for a long time, actually, that there's a natural condition uh, in which there's a foreign growth in the body. Growth not only allows new cells to multiply and develop new cells, but also old cells to be degraded, and the contents of those old cells spill into the blood. That normal condition is called pregnancy. So, when in the early days when I was training, we used to do amniocentesis to get a piece of the fetus DNA, and that's still done, in fact. But it's been discovered that fetus throws off DNA of its own that can be detected in the mother's blood. From that observation, developed the further observation that cancer, when it's again a foreign body present in a normal human, a cancer can throw off DNA, and not only is the DNA not only is the DNA normal DNA, but any mutations that in the DNA that are present in the cancer cell also can appear at various can appear in the peripheral blood. So again, a lot of it's not that simple. Again, how big does the tumor have to be in order for DNA to be detected? How common does the tumor have to? Does the DNA, the somatic DNA mutation, have to be detected? And are there sanctuary sites where a tumor is dying but doesn't have access to the blood, so it's dying and throwing off these DNA particles, but they may not be as accessible to the circulation, and that can affect the amount of circulating tumor DNA. Um, so, so having said that, gee whiz, if we detect, so again, a couple of amplifications on what I said. How do we differentiate the DNA damage from that sunburn you and I got when we were 12, which persists but is not causing cancer? So how do we sort that out from a cancer causing DNA or somatic mutation in our DNA? Secondly, it looks like a known cancer has to be about a centimeter in size before it throws off enough DNA to be detectable. And again, and how fast? How fast? It's unknown how fast, or it's unknown, right, to me anyway, how fast the tumor expands before throwing off detectable amounts of circulating tumor DNA.
Interesting. Can I ask you a kind of similar case study question? So again, not medical advice, not guidance, but just case study. So two case studies in this one. Case study one is, all right, I'm a breast cancer patient. I am in the metastatic setting, so stage 4 breast cancer. Should I get somatic mutation testing done?
Um, well, it depends. I mean, it, again, it depends. Um, so, what's the cheapest and most reliable? Probably a physical exam. So if you have a mass in your breast, and
Yeah.
we can, you and I, if you were the patient, you and I, as the doctor, could see that mass growing or expanding. That's pretty cheap, pretty available, and pretty low tech, but does require an experienced examiner. Um, uh, if we're going to change treatments based on the results, maybe a chest X-ray, simple, cheap chest X-ray, maybe a CAT scan or maybe a PET scan or something else can be useful. And also, the history, how you're feeling. Is this, if you have, in the thing you posed, metastatic cancer, is the treatment making you feel better? If it is, great, keep going. If it's not, then we have to sort out whether it's a side effect of the treatment or a side effect of the cancer. In that case, these other tests that I mentioned, physical exam, CAT scan, PET scan, etc., where many of your viewers may be familiar with tumor markers, CEA, CA15-3, CA2729. Those can be useful in settings of bony metastasis, where and particularly asymptomatic bone metastasis, where bone scans and CAT scans and PET scans aren't super duper reliable. So tumor markers can be helpful there. Similarly, circulating tumor DNA may have a place in that setting as well. There is a test now that actually is FDA approved that looks at that marketed by Natera, a Bay Area company, that looks at the tissue from the known cancer and develops a patient-specific panel of mutations that are found in that known tumor. So rather than searching around for 200 somatic DNA mutations, the Natera test then looks for those known mutations down the road. Down the road, meaning as time goes by. That can be helpful again in this, what I talked about in the it can be helpful in the bone metastasis case, whether it's a rich man's CA2729, a rich woman's CA2729, meaning it's better or the same but more expensive. I think we don't know. The I think really controversial area now is in the setting of a woman who's or man who's had breast cancer is potentially cured. Does circulating tumor DNA add anything?
Yeah.
Your viewers may remember in 20 or 30 years ago, there were, again, when there was an assay for circulating tumor cells. So instead of in the blood where there's red blood cells, white cells, and platelets, very rarely can there be circulating tumor cells. An assay was developed to detect those circulating tumor cells. Randomized clinical trial looked at circulating tumor cells monitoring versus standard monitoring, and the circulating tumor cell DNA did not improve survival, probably because the test main reason is that the treatments 20 or 30 years ago weren't as efficacious. There weren't as many of them. So if you knew somebody, if the cancer was growing 5 or 10 months earlier and you didn't have an effective treatment for it, so what? So things and similar studies were done with CA15-3 and CA2729 in women who were asymptomatic, didn't have detectable disease by X-ray or physical exam. Again, the circulating proteins, 27, 29, et cetera, didn't add anything. So there are clinical trials ongoing looking at this. The situation has changed. The test is probably more sensitive, and we have more treatment. So I think that's an interesting and particularly interesting and controversial. I will say, physicians, when posed, gee whiz, doc, if this was you, they're on both sides of the issue. Gee whiz, I wanted to know everything. And other times people say, docs will say, I'm living my life. There's no randomized evidence. Can be false positives, which can lead to a variety of invasive and potentially dangerous procedures. So don't do it. I think again, talk to your doctor, but that's where I think a lot, it's fair to say that, presuming that you agree that physicians are informed and also have their own personal health interests in mind, there's a division of opinion on that issue as well.
Thank you for sharing that. This specific where we ended up is something that is very near and dear to my heart, because I think I've been on both sides of it as a patient. I, without me checking really carefully, fairly soon after my treatment ended up getting a CTC test done with a company that had built it a long time ago. That doesn't have published data. And when I got the result, it was quote unquote positive, but there was no published data. So me, the clinician, we didn't know what to do with it. And a positive data on a test that is not FDA approved, but legally allowed to sell it under CLIA, without results that are published, it really sent me specifically on a spiral down the rabbit hole of CTCs, circulating DNA. What does this mean? What do you do with it? And then fast forward a year and a half now, to your point, I just gave the blood draw for Natera, because there was a use case where we're trying to I'm 3 years out from active treatment. My clinician wants to be monitoring, because I had and we can get into that later. In my specific case, my clinician was very comfortable with me not getting endocrine therapy, even though I am sort of ER/PR positive, or my tumor was. So in that use case, we were like, that's an interesting use case to be using the Natera test to see what the test might say in terms of survival use case. So I've been on both sides of it. And to be completely honest, I feel very not comfortable right now with a test result, because let's say it comes back positive. What in the world do you do with that? Because my imaging is great. Imaging says I'm good, right? So it's an interesting emotional balance as a patient to be there. And it feels a lot like, yes, there's data, yes, the clinician recommends something, but the burden also sits on you as a patient to see whether you want that kind of data. Do you want to be in that ambiguous space? And I don't think I have a good answer yet. I like data, and I think that's why I'm like, yes, let's do it, because I like data, I like the science, I don't mind being a guinea pig. And I think for those reasons, sure. But on the clinical side, as an actual patient, I don't know.
Well, let me just, you brought up the guinea pig. So who, in your particular case, if you're not part of a clinical trial, and I'm not wagging my finger, but I'm trying not to. But if one of your listeners and viewers is not part of a clinical trial, who is going to learn from that N of one? Well, great. N of one may help you or me or the individual, but it is not going to move our field forward. So I'll put in a plug here for a clinical trial, which is, a guinea pig has positive and negative connotations and meanings to various people. But I think the important thing is to balance risk benefit, but also to allow greater learning to take place.
No, absolutely. And I think that, Dr. Blayney, that's a absolutely beautiful place to sort of come to a close in part two, because it brings us in a funny way full circle back to the importance of ASCO, the presentation of data, the fact that this data largely comes from patients who are willing to be participants in trials, who are doing it, of course, sometimes for themselves to get access to treatment, but very largely the intention there is to give back to research, is to move the field forward, is to sort of dedicate part of their lives to the effort of scientific advancement. So in a beautiful way, we actually come.
Well, yeah, and let me just say that we as investigators have an obligation, and ASCO, I think, is trying to fulfill this obligation to report not only positive clinical trials, which we dealt extensively, but also negative, so that mistakes aren't repeated, and not mistakes, but pathway. We don't go down a non-productive rabbit hole. So even negative clinical trials, I think we have an obligation to make known, publish, and put in the medical literature, the public record.
On that beautiful note, thank you, Dr. Blayney, for joining us again. Thank you for sharing an incredibly educative session.
All right,
and really
Samira.
going into basic biology, which I know a lot of our listeners really appreciate, because a lot of the science, it's hard to understand, and understanding the kind of basic biology helps put drugs and advancements in context. So thank you for doing that.
All right. Thanks, Samira, and thanks for your listeners' time and attention.
This podcast, show notes, and newsletter is for general informational purposes only and does not constitute the practice of medicine, nursing, or other professional healthcare services, including the giving of medical advice, and no doctor-patient relationship is formed. The use of information on this podcast or any materials linked from this blog is at the user's own risk. The content here is not intended to be a substitute for professional medical advice, diagnosis, or treatment. Users should not disregard or delay in obtaining medical advice for any medical condition they may have, and should seek the assistance of their healthcare professionals for any such conditions.